invite Dr. Padma Paul from CMC Velo to kind of share with us what are the models that are available when you have to communicate with both patients and their attenders.
Thank you so much, Dr. Kaushik. I hope in the next few minutes I can walk us through the purpose of communication, dealing with the stakeholders, some of the options that we have for this process, and whether we can ever be prepared for this, and what can we do if it does happen. So does communicating about endophthalmitis qualify to be breaking bad news? Even if it's not life-threatening, loss of one sense, because it's a potentially blinding condition, it does qualify, and it has to be done with care. If you walk with the patient, it may not be so bad after all. So why is communication important? Patient's comprehension determines the compliance, the emotional adjustment, satisfaction with medical treatment, and the psychological state post-communication. You have to remember that this is not just one patient. In a situation of a cluster, ineffective delivery increases anxiety almost exponentially. Potentially bad news has to be delivered with professionalism, patience, and empathy in a situation where the outcome may be uncertain, may or may not have a negative impact, but you have to prepare them for a worst-case scenario. When you're dealing with a cluster, you're dealing with more than one patient and families, sometimes communities and other hospitals. The challenge is that the eye care system may be implicated. So physician is also under stress. In a cancer situation, you're not responsible. Here, you're short of time. You have to make these difficult decisions, do these endophthalmitis vitrectomies through the night, at the cost of the antibiotics, additional consenting, and sometimes if you don't have vitreoretinal services, refer them for further management. The scenario is constantly changing, requiring updates. So who are the stakeholders we're looking at? The treating surgeon has to deal not just with the patient and the relative, management authorities, community which may be angry, and the government which is looking at you. And it's not just one set, but in a cluster there are several. Remember to customize the communication to the patient at hand, because different patients may be at different ends of the spectrum. The relationship starts at the time of informed consent, so the patient in some part of the hard drive knows that this was told to me as a remote possibility. One important step is to decide as a team what is the message you're going to convey and stick to it across the board, because the relatives will try to meet different people of the team to find out more information. Who should communicate? Preferably it should be the head of the unit or a senior consultant. Managing the media, etc., can be done in partnership with the management, but the physician has to be directly informing the patient. What has been found is that this important part of treatment is very casually overlooked in our training programs. Everybody has expressed the need to be taught this kind of communication, and it has worked in some pilots that you actually teach residents and fellows how to communicate under these difficult circumstances. So the goals of communication are to gather information about what the patient already knows so that you can take it from there. Give information in an understandable layperson language, support the patient, express hope, the treatment plan, and the outcome. Important considerations before the interview is to confirm facts. Do not go and talk to a patient depending on the findings of a resident. You may regret it. You have to be composed yourself before you speak to the patient. Be actively listening and give the patient time to process what you're saying. All information should be based on evidence and understanding, and make sure you document what has been conveyed. After this, you will have to periodically update what has been said and patiently answer each time, especially the relatives. The most commonly used approach is spikes, which was elaborated by Bale et al., used for oncology, but seems like it could be adapted for this as well. Setting is what S stands for. Have a private setting, introduce yourself, have adequate body language. The physician needs to minimize any evidence of nervousness in their own tone or body language. involved relatives so that they can support and help for the patient when the patient is not in a condition to process what you're saying. Manage your time well and avoid interruptions. Before you tell, ask. The P stands for perception, so that you know where to take off from. Also check that the patient is not in illness denial. You are saying that this is a difficult situation. Patient doesn't want to hear it, so hears it like, oh, it should be all right. Then you ask the patient if they're ready for the rest of the information that you want to give. Always refer to the team collectively as we rather than I, especially relevant in endophthalmitis as the eye care providers, reviewing information of several patients and sometimes divulging this to the public if necessary. The most important thing, as even conveyed by patients, is the content. Remember that the patient is very astutely observing. If it knows that the system is designed to pick this up early and treat, you're in a better situation. Once there is a suspicion of cluster, tailor the information for each patient. Use simple words, avoid excessive bluntness. We should gently alert the patient that there may be an issue. Sometimes we call them from home if they've been operated on the same theater day. It's good not to alarm them, but just to warn them gently using kind words. Once there is a suspicion of infection, we have to convey about the testing, the need for injection, need for surgeries, and tell them that there is treatment nowadays which can actually handle it if possible. Don't give large chunks of information at a time, and definitely not say nothing can be done. Be prepared for to be asked more questions. If we have had to refer the patients for a vitrectomy, stay in the loop and remain involved. Respond to emotions with empathy, needless to say. Summarize what has been said so far and then go on to the strategy of what the treatment plan is going to be. Share the responsibility for decision making. It's very distressing if the first time you hear this is when you have been called into theater to be given an intravitreal Avastin. The only experience that has been reported in ophthalmology is in sharing bad news about glaucoma. Patients have said that 1 in 3 felt that the doctor was saying incomprehensible terms, and that many doctors downplayed their condition. However, training residents has shown that outcomes have improved, so it may be worthwhile to consider this as a preemptive exercise. The important don'ts: we should not make judgmental comments, we should not distort the truth, withhold or overload with information, or give false reassurances. Do effectively communicate with patients with the right balance of honesty, empathy, and concern. It's very hard to do. This reassures the family and the physician and protects both from the onslaught of misinformation that may come through the media if we are not careful. So patients did say that the most important thing that they would like to know is correct content, along with other supportive dimensions. Other alternate models are the ABCDE models, which are very similar to the SPIKE and the Piotr protocol. Most important barrier to effective communication is that as a result of this anxiety and burden of responsibility, we may go mum, which means you don't communicate, and that is a dangerous situation to be. So what can we do? We here in this room hope and pray none of us need to be in this predicament, but it is not unwise or it's wise to be prepared for this. Train a team, train our residents, and have a standard operating procedure in place should you ever have to reach this. Support colleagues at the time of the crisis. This cycle of communicating, updating, reviewing has to go on constantly till the crisis has blown over. So the take-home message for the doctor is to be available, be vulnerable. That means you have to face anger and be questioned at all times. The patient has to be part of the process and participate. Relatives have to be informed, support, and retain information that the patient may have missed in his anxiety. As has been said, do it badly and the patient will never forgive you. Do it well and the patient will never forget you. Thank you.